Okay, good afternoon. Thank you very much, Dr. Twahir, for the kind introduction. Today I'll be talking about fungal infections post-transplant. So if you look at the overview, infections and rejections are the most common complications post-transplantation. And the types of infections differ depending on the type of transplantation. It is also dependent on the patient's past history and the associated risk factors that the patient has. The timing of the infection also is dependent on the level of immunosuppression. So earlier on, because we have the maximum level of immunosuppression immediately after the transplant, that's where we have the highest risk of most of the infections, as I'll show you. If you look at the causes of mortality in kidney transplant patients, cardiovascular mortality is obviously the highest cause, followed by other causes of mortality that are not related to what is displayed here. Infection is the third most common cause of mortality in transplant patients, especially in kidney transplant patients. So this is something I believe that all of us need to be aware about and need to watch out for in our kidney transplant patients. If you look at the acute rejections over the past 2 decades, the rate of acute rejections has reduced considerably. Our 1-year graft survival has basically improved to more than 90%. However, if you look at the long-term outcome, this still remains a challenge in kidney transplantation, and this has been going on for the past 4 decades. Nothing much has changed, and there's been no improvement in terms of our long-term outcomes post the kidney transplantation. So why hasn't there been an improved, why hasn't improved early graft survival resulted in better late graft survival? So if you look at it, one of the reasons is the immunosuppression. The immunosuppression may have early benefits, but late adverse effects on graft survival. We all want our patients to be producing good amounts of urine with the creatinines to be perfectly normal immediately post-transplantation. There should be no rejection. And the rejection risk is highest immediately post-transplant. So we tend to use very high levels of immunosuppression, but of course this comes in with its own collateral damages like infections. So most commonly we tend to get BK nephropathy, but there are also other late infections as well. Like you'll see fungal infections. Malignancy is another reason as to why we haven't gotten better late graft survival and cardiovascular disease. Late graft survival may also occur via mechanisms that are unrelated to immune injury, like drugs and recurrence of the disease. And another reason is because subsequently when the patients become complacent, then they may become non-compliant or non-adherent to the medications, and this will subsequently lead to late acute rejection. So, but for this talk, we're basically going to be talking about infections and mainly fungal infections as a result of loss of the graft as well or mortality. So if you look at the infections in immunosuppressed patients, the basic principles are that the inflammatory response is attenuated by the immunosuppression. So because of the fact that we are not allowing the body to mount an inflammatory response, it may abolish the typical signs and symptoms of infection. And there's also the decreased sensitivity of serological and radiological tests. So we need to keep that in mind, and we need to have a very high index of suspicion for these kind of patients who come in with the possibility of infections. And once when the infection is established, the effects may be quite devastating. The treatment of the infection itself may have more toxicities. Remember that we will have drug-to-drug interactions as well, or we can have synergistic nephrotoxicity. So drugs that basically are going to increase the metabolism of your anti-transplant medications like rifampicin will decrease the levels of your CNIs. Erythromycin and azoles, which inhibit the cytochrome P450 system, basically increase your CNI levels and can lead to nephrotoxicity. Then the drugs that are used to treat infections can also cause nephrotoxicity as well, like your aminoglycosides, your amphotericin B, and high doses of cotrimoxazole to treat the pneumocystis jirovecii pneumonia. When you look at infections in transplant patients or transplant recipients, it basically depends on the net state of immunosuppression and the epidemiological exposure. So when you have somebody who's undergoing transplant, these patients are already on widespread prophylaxis. These patients are on nystatin to prevent oral candidiasis. They're also on CME prophylaxis. They're on ganciclovir. And initially, they're also on very important immunosuppression. Now, this basically can lead to an infection, and because of this potent immunosuppression, we can get modified presentations based on the symptoms, the timing, and the spectrum of the disease caused by the bacteria or the virus or the fungi. And because of the widespread prophylaxis, we can also induce drug resistance as well. So this is something we need to keep in mind when we are dealing with a patient who has developed infection post-transplant. So most of these patients are in a net state of immunodeficiency, and the net state of immunodeficiency can be caused by the immunosuppression itself, like what the current regimen the patient has been on, and what was done before as well. Like if you use induction therapy, like ATG or basiliximab, what were the prior therapies the patient was on? Was a patient on chemotherapy? Was a patient on broad spectrum antibiotics? How about the mucocutaneous barrier integrity? Is it intact? Does the patient have indwelling catheters, lines, or drains? Does the patient have neutropenia or lymphopenia because of the drugs? Underlying immunodeficiencies, like in our setup, does the patient have HIV, or was the patient having lupus, or was the patient having hypogammaglobulinemia? The metabolic milieu as well is important, like for our patients who are uremic, or was the patient malnourished because of CKD, was the patient diabetic? Viral co-infections like viruses like cytomegalovirus actually predispose to other infections like fungal infections. And what was the risk assessment done in the transplantation, and what therapies were used at that point in time? The greatest infectious risk is when you've used induction therapy. For example, if you want to deplete the lymphocytes like ATG, high dose steroids. Was the patient given plasmapheresis to reduce the risk of rejection? Did the patient have a high rejection risk, like high PRAs, or was the HLA typing 0 out of 6 match? Early graft rejection is also predisposes you to greater infectious risk, because you will basically subject the patient to high dose steroids, you'll subject the patient to plasmapheresis or ATG. Did the patient have an active or a latent infection? Like, I mean, from the donor as well. Like, if the patient, if the donor had a CMV infection, it can be transmitted to the recipient. Technical complications during the surgery, anastomotic leaks, bleeding, wound infections, or poor wound healing are all factors that can lead to invasive infections as well. Prolonged intubation post the transplantation is another risk factor for infections. Vascular urinary catheters that have been left for very long can also predispose a patient to a greater infectious risk. So these are the type of patients who have a lower infectious risk. The patients who have a good HLA match. The surgery was a simple and a successful surgery. They achieved immediate good graft function. Appropriate surgical prophylaxis was administered, and they had effective antiviral prophylaxis and PCP prophylaxis, and they were given appropriate vaccinations before the transplant itself. Epidemiological exposure, as we said, was the second thing that we needed to look at. It can be because of the donor-derived infections or the recipient-derived infections as well, whether the recipient had some latent infections that I talked about, or did the patient get a community-acquired infection post-transplant, or was this infection acquired in hospital during the transplant or after the transplant, or the patient came in for one reason or another, like if they came in for treatment of rejection. This is the usual sequence of infections post-transplant. We'll focus on the fungal infections because this is what the talk is about. Candida infections can occur within a few weeks post-transplantation, within 2 to 6 weeks within post-transplantation, because that is when your immunosuppression is the highest. You can get aspergillus 1 month after the transplantation. Pneumocystis infections can also occur immediately after, 1 month immediately after transplantation. Cryptococcus tend to occur a bit later on, normally 4 months after transplantation, and the geographically restricted endemic fungi also occur a bit later on. But this does not mean that the patients cannot get these kind of infections even later on. I mean, we have seen patients getting aspergillus infections even 2 years post-transplant, or even 4 years post-transplant, and even Candida infections. So if you look now specifically at fungal infections, they become more important as a cause of infectious mortality, especially since we have got improved strategies against cytomegalovirus. CMV used to be the most common cause of infectious mortality, but because we've been using prophylaxis and screening our donors and recipients quite well, and actively looking for cytomegalovirus infections, we have actually reduced the mortality. Candida and Aspergillus accounts for approximately 80% of invasive fungal infections. So this is important to note that if you're suspecting fungal infections, we need to use drugs that are going to target Candida and Aspergillus. The other 20% are caused by Cryptococcus, the other molds, and the endemic mycosis. The incidence of invasive fungal infection post-transplants, the most common transplant that can lead to invasive fungal infections is intestinal for obvious reasons because of the Candida. Then subsequently, you can get it in liver transplantation up to 42%. Renal transplants, the incidence of invasive fungal infections post-renal transplant is 0 to 14%. So if you look at our fungal players, we have our opportunistic fungi, and we can have the normal flora that basically, once you get immunosuppression, can become pathogens like Candida species. Then there are those that are ubiquitous in our environment, like Aspergillus species, the Cryptococcus species, and the Mucus species. There are those that are endemic and geographically restricted, like the Plastomyces coccidioides and the Histoplasmosis, which are normally found in North America. The classification of fungal infections, there are three types. There are three classifications. You can classify them on the site of infection, whether it is mucocutaneous, like your oral candidiasis, or they're the deep organ infections. You can classify them epidemiologically, whether they're endemic or opportunistic infections, or microbiologically, whether they're yeasts, molds, or dimorphic fungi. Dimorphic fungi basically are those that have the hyphae and the yeasts together. The structure of the cell membrane and cell wall of a fungus is demonstrated here. So the picture on the right basically shows you the cell membrane, and it consists of the phospholipid layer. There's a protein and the sterol. The one on the right shows the cell wall, and it consists of the fibrillar layer, the manoprotein, beta glucan, and the cell membrane. So these structures of the cell wall are basically used in terms of your therapeutics as well as in terms of diagnostics. Like we can use the beta-D glucan in terms of diagnosing fungal infections, and you can also use echinocandins, which basically inhibit the beta-D glucan synthesis. Candida, which is the most common cause of fungal infections, be it in transplant patients or the non-transplant patients. There are more than 150 species of Candida, but very few of them cause diseases in humans. Now, it's important to remember that the Candida species they are the normal commensals, which are found in the gastrointestinal tract, the skin, and the genitourinary tract. And we divide the Candida into the albicans species and the non-albicans species. So that's very, very important because it has implications in terms of therapy. The non-albicans species, the most common ones include your Candida glabrata, cruzei, tropicalis, paracellosis, lusitania, and the Guillermondi. So the way in which the Candida causes disease is that it gains access to the bloodstream either through the GI tract mucosal barrier or via an intravascular catheter like our central lines or from a localized focus of infection. Most commonly, it is through the GI tract mucosal barrier when there's a breach of the mucosal barrier or via an intravascular catheter. And that's why it's important to assess our patients and make sure that if our patients do get an infection, and if they have a line, a central line, then we need to change the line as a first line of therapy. In 2008, there were more than 29,000 organ transplants that are performed in the United States, and we have increased immunosuppression and multiple organ, which has led to an increased incidence of invasive fungal infections. The other causes of increased incidence of invasive fungal infection is multiple organ transplantation, as well as environmental factors. So the transplant-associated infection surveillance network conducted a 5-year prospective survey among more than 1,000 transplant recipients, and they diagnosed more than 1,200 were diagnosed to have invasive fungal infections. Now you'll wonder why the numbers are different. If there are only 1,600 patients, 1,063 patients, and we got 1,208 who are diagnosed to have invasive fungal infection. This is because some of the patients got more than one fungal infection. So you can see that it is quite prevalent. And the most common invasive fungal infections in this study were invasive candidiasis. This was the most prevalent invasive fungal infection. More than half of those patients had invasive candidiasis. Almost 20% had invasive aspergillosis, 8% had cryptococcosis, 8% had the Aspergillus molds, 5% had endemic fungi, and only 2% had zygomycosis. So empirically, even if you suspect fungal infection, then you know that if you treat Candida, more than half of the times you're going to be right. So with the use of more effective immunosuppressors, most of the fungal infections, as I alluded to earlier, occur within the first 6 months post-transplant. The median time to the onset of candidiasis is also dependent, the median time to the onset of the fungal infection is also dependent on the causative agent. So the median time to the onset of the fungal infection after transplant was, for Candida, it was 103 days. For aspergillosis was almost 6 months, 184 days. And for cryptococcosis occurred after 1.5 years. So if you look at the clinical presentation of invasive fungal infections, the transplant patients, as I mentioned earlier, usually present with vague clinical symptoms of infection. So you need to have a very high index of suspicion when you get a transplant patient who has got a fungal infection. And remember that also the early laboratory tests also will most likely reveal normal parameters. So the clinical indicators of a fungal infection will include unexplained fevers, despite broad-spectrum antibiotics for more than 3 to 6 days, recurring febrile episodes after initial defervescence, and if you have aspergillosis, you can get presence of pulmonary infiltrates during antibiotic treatment when the patient was responding to the treatment. The mortality rates are quite high. Candidemia has a mortality rate of approximately 40%. Invasive aspergillosis, the mortality rate is reported to be more than 50%, it's actually 58%. And the mortality has significantly gone up from 1980 to 1997. And mortality continues to be high regardless of the antifungal therapy that is used. So what are the challenges when it comes to treatment of invasive fungal infections? Now, and treating invasive fungal infections. One is that we tend to delay antifungal therapy until the blood cultures are positive. And that is quite detrimental because it is associated with increased mortality. The second one is that we have quite a bit of diagnostic limitations when it comes to diagnosing invasive fungal infections. Now, this was a study that was done by Morale et al., and this showed that by delaying your antifungal therapy, your risk of hospital mortality progressively increased from less than 12 hours to more than 48 hours, leading to almost 35% mortality by delaying it only by 2 days. So you need to have a very high index of suspicion that this patient could be having an invasive fungal infection and start empiric therapy while you're waiting for your blood cultures. Now, it's also very important to know that we need to start empirically and also initiate source control. Because if you don't control the source of the infection, like if it's a line and you don't remove the line, your chance of mortality becomes very high. So this was a retrospective study between 2002 and 2010, and they had more than 200 patients who had candidemia and septic shock. The overall mortality was 63.5%. Now, despite source control and antifungal therapy within 24 hours of onset of shock, more than half of the patients died. Now, without source control and treatment was delayed for more than 24 hours, almost 100% of these patients actually died. So you can see that it's important to, one, if you have an index of suspicion that this patient could be having a fungal infection, you need to start the treatment immediately while you're waiting for the cultures. And if there is a known source of the fungal infection, then you need to get rid of the source. Otherwise, your mortality tends to go up significantly. So what are the diagnostic armamentarium that we have? We have blood cultures, but unfortunately, in more than 50% of cases, the blood cultures tend to be negative in invasive fungal infections. We can also use culture and stain of biopsy materials, especially if we suspect the focus of infection. There are the non-culture methods that we can use. Remember I talked about the beta-D-glucan, which is found within the cell wall. We can also use the galactomannan and the mannan assays, and PCR, especially for Candida, which is now currently available in Kenya. We can use Candida PCR, and it's quite sensitive. So if you look at beta-D-glucan, is present in the cell wall of many fungi. It has a slightly low sensitivity of 70%, but the specificity is much higher. You can get many false positives, especially if somebody is on beta-lactam antibiotics. If somebody is on hemodialysis, they tend to get false positives. So it's mainly used for its negative predictive value. And it can also be used as a prognostic marker of the treatment response in invasive candidiasis as shown by this paper. So they had 257 patients with proven invasive candidiasis, which were enrolled in the Andidula fungin study, which is an echinocandin. And what they looked at was the clinical and microbiological responses at the end of therapy. And the serial beta D glucan levels were measured. So the correlation of the initial and final beta D glucan levels were assessed with the overall outcome in each patient. These were the characteristics of all the patients. And what they concluded was that a decrease in beta D glucan levels during therapy is associated with treatment success. And an initial beta D glucan level of less than 416 picograms per mil has a potential to predict successful treatment outcomes. Now, unfortunately, our turnaround time to get the beta D glucan is quite high. In my hospital, it can take up to 7 days to get the beta D glucan levels. I know that Aga Khan Hospital used to do the beta D glucan level and then they subsequently stopped. So again, it becomes quite difficult to use this, especially in our setup, to be monitoring the response to therapy. So we mainly use the clinical parameters and other laboratory parameters. Invasive aspergillosis is another common fungi that can occur post-transplant. It is quite ubiquitous in our environment. The frequency of invasive aspergillosis is increasing, and the most common species are the ones that I've mentioned, the fumigators, flavus, niger, and terriers. The risk factors for invasive aspergillosis is severe and prolonged neutropenia, receipt of high dose of glucocorticoids, like what happens in our patients, and chronically impaired cellular immune responses. Again, our patients, we tend to use our transplant rejection medications, which basically impair the cellular immune responses. So this is a perfect milieu for our patients to get aspergillosis as well. The diagnosis, again, blood cultures have limited value. We tend to use a lot of bronchoalveolar lavage where it's available. If you do have a cavity or if you do have a fungal ball, then we can use transthoracic percutaneous needle aspiration or the video-assisted thoracoscopy to make a diagnosis. So most commonly, we tend to use the radiological screening tools like a CT scan, where you can get characteristic features. And the halo sign it is specific quite in the patients who develop invasive aspergillosis. Its sensitivity varies with timing relative to the diagnosis. We can also use beta D glucan assays, but again, as I mentioned, it has got excellent negative predictive value, and it can get false positives as well. PCRs, it has 100% sensitivity for invasive aspergillosis. We can use the galactomannan assays. They have a higher specificity of 81% and a lower sensitivity of 73%. Again, you can get false positives when you use the galactomannan assays for diagnosing invasive aspergillosis. These are the classical features that you can get. The halo sign, this is on the CT scan on the left, and you can get the air crescent sign here, which is on the right, where I'm pointing with my arrow. So if you look at antifungal that are available to treat the Candida species, what we need to remember is that for the azoles, especially fluconazole, it is resistant to Candida glabrata and Candida krusei. So if you have a patient who has grown either the Candida glabrata or krusei, then we cannot use fluconazole. That's very important to note. The echinocandins, caspofungin has got less susceptibility to parasilosis, but it can be used for the other the other Candida. Amphotericin B also has less susceptibility to Candida lusitania. So if you look at amphotericin B, it has a broad spectrum of activity and fungicidal action. It is a drug of choice for many life-threatening mycotic infections. Unfortunately, the main risk that we have with amphotericin B, especially in our transplant patients, is nephrotoxicity. It does tend to cause quite a bit of nephrotoxicity, especially the conventional amphotericin B, and that is why now we have the liposomal preparations of the amphotericin B. And the liposomal preparations are packaged in a lipid-associated delivery system to reduce binding to the human cell membrane. So therefore, it does tend to reduce the nephrotoxicity and the infusion toxicity. Unfortunately, these are very expensive, and they're even more expensive than the echinocandins. 1 day's dose of liposomal amphotericin B, if you're using 5 milligrams per kilogram, which is a conventional dose, can easily cost you around 80 to 90,000 shillings just per day. And remember that you're supposed to treat the patient for a minimum of 2 weeks. So you can imagine that the cost is going to be quite phenomenal when you're using amphotericin B. Fluconazole is a very well-known drug, quite cheap, very tolerable. It has activity against Candida parasilosis. Unfortunately, it has no activity against Candida krusei. It has 50% resistance against Candida glabrata, so you're supposed to double the dose in case if you're left with no option. High levels of resistance develop, and it has limited activity versus against a biofilm. Remember that especially in our patients who tend to have invasive catheters, so we need to always, we preach that we need to remove the catheters in case if we develop any invasive fungal infections. The other disadvantage with fluconazole is that it's fungistatic. And of course, it has various drug-to-drug interactions. Remember that it's an inhibitor of cytochrome P450, so it can increase your levels of your CNIs, especially if you're using it in post-transplant patients who are either on tacrolimus or cyclosporine. So if you put a patient on fluconazole who are on cyclosporine and tacrolimus, you need to monitor the levels more closely, otherwise you'll end up developing CNI toxicity, which can lead to graft loss. Voriconazole is another azole. It's a broad-spectrum antifungal agent. It can be given orally or intravenously. Unfortunately, the intravenous formulation is contraindicated in renal dysfunction because of the vehicle it uses, the cyclodextrin. It can accumulate in renal dysfunction and cause toxicity. It has a high oral bioavailability and penetrates tissues quite well, including the cerebrospinal fluid. It's an inhibitor of cytochrome P450, just like the other azole fluconazole. Therefore, it has got quite a bit of drug-to-drug interactions. And if you're forced to use it, especially if you get invasive aspergillosis, it's a drug of choice as a first line. You need to be careful when we have patients who are on cyclosporine or tacrolimus. It has been shown to cause reversible visual disturbances. So you need to make sure that at least these patients go for regular checkups, especially if they're on long-term therapy with voriconazole. And the other disadvantage of using voriconazole is that it has zero odor kinetics. And that is why the FDA actually recommend that you're supposed to do the therapeutic drug monitoring for voriconazole, which is not routinely available. Echinocandins are the relatively new kids on the block. They are quite broad in their spectrum of activity against the fungi. The resistance is very rare. In my years of practice, I've only seen one case of Candida auris that had developed resistance to echinocandins. They have very good biofilm activity as well. So they can be used, especially when you're still trying to search for the focus of infection. They're fungicidal and they have a very good safety profile and very limited drug-to-drug interactions. However, they can reduce the dose of cyclosporine. So if a patient is on cyclosporine, especially our transplant patients, we need to be monitoring the levels more closely. If you have liver dysfunction, especially Child-Pugh 2 and 3, then we need to dose adjust our echinocandins, especially the caspofungin, we need to reduce the dose. So instead of the loading dose of 70, we give a loading dose of 50, and then subsequently continue with 35 milligrams once daily, rather than 50 milligrams once daily. So if you look at the treatment of invasive candidiasis, this is from the IDSA 2009. So if the patient is a stable patient and whatever fungi that you're dealing with is going to be sensitive to fluconazole, then you can use your fluconazole. You can give your treatment doses, load with 800 milligrams and continue with 400 milligrams. If the patient is unstable and the patient has septic shock, then please don't use your azoles, go straight for your echinocandins, okay, straight away, while you wait for your cultures. And then if you get your cultures back and if they're sensitive to fluconazole, then you can switch to fluconazole. If not, then you continue with your echinocandins, okay? Duration of therapy, this is very, very important. If you have a culture that is positive, then you need to continue the duration of the therapy of the antifungal for up to 2 weeks after the first negative blood culture. That is very important. So I've seen cases whereby the therapy has been stopped after a week or 10 days. But the right thing to do is to keep on culturing the patient. If you get a blood culture positive, repeat the blood cultures on alternate days. And then when you get the first negative blood cultures, you count 2 weeks after that and then stop your antifungal therapy. A longer duration of therapy is required for patients with metastatic foci or endocarditis. You can go up to 6 months of therapy, even with osteomyelitis as well. So in summary, the incidence of infections post-transplant is increasing, mainly due to the more potent immunosuppressive regimens that we are now currently using. Also, we're using a lot of induction therapy as well, especially with ATG. So this has been shown to increase the incidence of infections. The most common invasive fungal infection is invasive candidiasis. More than half of the patients will get invasive candidiasis, followed by invasive aspergillosis. Most fungal infections occur within the first 6 months post-transplant, but remember that they can occur at any time after the transplant as well. So we need to have a high index of suspicion. The transplant patients present with non-specific symptoms of fungal infections. Very important to remember is that the blood cultures can be negative in 50% of cases. So if you have a high index of suspicion that this patient could be having a fungal infection, then you need to start the therapy empirically and assess and see how the patient responds. You have to take into account the drug-to-drug interactions when selecting the antifungal agent. And please remember that the duration of therapy, especially if it's invasive candidiasis for candidemia, is that it has to be 2 weeks after the first negative blood culture. So I'll stop there. Over to you, Dr. Tahir. I hope I've kept time.